One. I've had to close off my ability to see your faces or your blank screens, but it's a pleasure to be with you. Again, I'm Dr. Inese Verzemnieks from the School of Nursing, and today I've got two lectures, probably more content than can fit in the 90 minutes that we've brought me down to. But the first one will be this understanding fundamentals of developmental screening, and then I'll switch slides and I'll give you an introduction to home visiting and the nursing role in that for especially early childhood, since that's an area that we're all interested in. So understanding the fundamentals of developmental screening tools and resources. This is a presentation where I've got some of the slides have been done from Lourdes Moreno, who is a master's prepared developmental specialist that works at Pathways LA, and she allowed me to share some of the slides. So the objectives for today really are to introduce you to Bright Futures, which is an evidence-based guidelines and research source material area that you will maybe find of interest if you haven't already been exposed to it. And I know that I don't know the specifics of all the pediatric content that you have. So while I'm talking, don't hesitate to say, to mention if you've had some of the content already. And then we can kind of go over it even more quickly. But at one point, this information was not provided in the same format, I think, with the PEDS primary care. So want to distinguish between the terms developmental surveillance and developmental screening as it's used in pediatric primary care. And, you know, that you would be able to indicate what things are universal and periodic in screening recommendations for pediatrics, identify at least one sensitive and specific parent-completed developmental screening tool that can be used in PEDS primary care, and identify resources available to understand normal and deviations from normal, as well as other developmental assessment, and introduce you to some of the referral resources that are available to all of us in the community. So have you had any content on Bright Futures?
I don't think so.
Oh, good. Excellent. So this is a compendium of materials that are available. They were recently updated a couple of years ago. So if there's anything that you are interested in, routine, general, pediatric, anticipatory guidance, basic, screening and healthcare, these resources are excellent. They are supported by a whole host of professional organizations, including the American Academy of Pediatric Dentistry, the American Dental Hygienists Association, the NAPNAP, the Pediatric Nurse Practitioner Group, and American Nurses Associations, school nurses, American Medical, American Academy of Pediatrics. So all of them have come together to provide a resource. So this is a busy slide here in terms of that periodicity chart. Have you seen that before?
I don't think so.
Okay,
it's a little small, so that's kind of hard to see.
Yeah,
kind of small.
Yeah, I'll be showing it to you in a little bigger category, but this is what we call, this is the schedule that is followed in ambulatory pediatrics for child well visits. And so the periodicity schedule, and it has various dots, so I'll show it to you in a little more close-up in a few slides, but it tells you when you screen, when you do certain measurements at each visit. And then there are footnotes down below, and there's even a second page of this that includes extensive footnotes. And it ends up having, oh, good, yes, and it has all the immunizations. Good, thank you, Stephanie, for saying. So, that tells you what to do, and then the Bright Futures Guideline, this book, tells you how to do it and how to do it well. And on the previous slide, this one here is the link that you can all use, and you can download the materials. Almost all of them are free. There may be a few pages missing in some of the documents, but basically they're available to you, and there's some really good pocket guides. So as well as then this evidence and rationale. So if you're curious about things that are necessary, so for example, this is part of the evidence and rationale chapter for elevated blood level. And so at 12 months in high prevalence areas, at 2 years in high prevalence areas or Medicaid, you know, they recommend testing for lead levels. So you first would do maybe some risk assessment. Does your child live or visit a home child care facility that has identified lead hazards or built before 1960? In California, it's actually built before 1978 is the screening risk assessment measure. So it's actually a little bit later than the 1960 group. So there's lots of great, you know, information, rigorous guidelines, and then the evidence that you can follow as well. So the screenings that are done, as well as anticipatory guidance, can be found in these volumes. But for example, maternal depression screening is a new screening that's done in pediatrics every month from the first month through 6-month visits. Because of the seriousness of maternal depression and identifying it early. Oral health, this has been part of the recommendations for since 2014, and the universal fluoride varnish at the 6-month visit through 5 years, every 6 months, and assess children for risk, and indeed tried to get them into a dental home. Then depression screening for adolescents. At one point it was not recommended because of limited services, and now it is recommended. They also have materials for practices that make assessment and parent pre-visit information pretty simple. And they also have a series of oral health pocket guides for medical practitioners. These were last updated in 2016. They're also available for a free download. So this is then that close-up of the periodicity chart, and it's available. It was last updated 2019, and you can click on, in the PDF, you should be able to click on the URL and get to the most recent document. But down here, you'll see there's the oral health, and it talks about fluoride varnish as well as fluoride supplementation if indicated, and it refers you to footnotes that tell you when and where you should do it and where you can find more information. So the developmental and behavioral health, which I'm going to focus on more today to introduce you to some of the instruments and why it's really important. But they talk about doing developmental screening, so they have a dot here that indicates doing it at 9 months of age. So this, I just showed this first, you know, the green section. That the autism spectrum screening, well, you'll hear about that. We don't do that till a little bit later. Developmental surveillance, we do this at every visit, and you'll find out what that means. And then psychosocial behavioral assessment. You'd be looking at that. And then maternal depression screening at 1, 2, 4, 6 months. Now, every practice may be different. I'll share with you, my daughter just had a baby and just had the 2-month visit, and her pediatric practice did not have the 1-month visit. They had a 3-day visit with the pediatrician and then a 2-week visit, and then did not have the 1 month and had 4 months. So all practices vary, and there are different footnotes for all of these. Then also California, with the Child Health and Disability Prevention Program, that's what CHDP stands for, they have their adaptation of the periodicity chart, and it's similar in some ways, and also has recommendations and requirements. However, as you see there, developmental screening has one of these open circles. And so that means recommended to do, but it's not necessarily required to do, which I think brings us into some problems in California particularly. So what's going on in California? Children Now gave us a report card in 2018 that said we had a grade C- in looking at developmental screenings. And as you saw there in that previous slide, it's not required that, that practices use screening and do screening, and you'll understand the difference between screening and surveillance in a moment. But 1 in 4 children are at risk of developmental, behavioral, or social delay in California. That means about 625,000 children, in the state. So a quarter of those are definitely need services. The rate of parent-completed developmental screenings is variable, but it never reaches a 50% point even. Look at this. We've got 23% of Latino parents are asked to complete a developmental screening, 31% of white, 22 Black, 16% Asian, 29% of others. So this is not a uniform practice, and not the uniform screening and universal screening that the American Academy of Pediatrics recommends. So this is their recommendation. It has a interesting title, Identifying Infants and Young Children with Developmental Disorders in the Medical Home, an Algorithm for Developmental Surveillance and Screening. So this was initiated in 2006, has been reaffirmed as well, and it has some background information on the various different tools. So in that document, they talk about surveillance, and surveillance in terms of pediatric practice and screening for developmental problems is a flexible, continuous process whereby knowledgeable professionals perform skilled observations of children during the provision of healthcare. So that basically really means your clinical judgment. And it's done every visit. Now, screening, however, is a brief assessment procedure designed to identify children who should receive more intensive diagnosis or assessment. So it's aimed to identify those children who might need some more comprehensive assessment, and helps professionals judge whether development is progressing typically or if there are some causes for concern. And the important proviso is any screening instrument is not diagnostic of developmental delay. So the challenge is, particularly if we wait for the delay in a skill to become evident, it might delay other milestones. It might be a precursor to various other skills, and it might be based on just clinical judgment. So this universal screening is highly desirable. If we wait for a skill to be missed, it usually results in very late recognition and then delay of intervention for children. Especially important is this recommendation of language skills early on. And, in a pediatric practice, we would be concerned if language doesn't begin to develop, that there was maybe hearing loss or some other diagnoses. And child development is kind of hard to measure. Children do develop in spurts. There is a discontinuous nature of development. You hit plateaus and then you continue on. There's some variation of developmental skills, because I want you to remember that children do not develop skills just automatically on some time grid, but it's by experiencing the environment that they gain those skills, and the myelination that occurs with many of these important developmental accomplishments. And it requires that the child cooperate with the examiner. So, many times if we do like a test, or it's identified as a test, that can really provoke a lot of anxiety for parents. So in general, it is really the periodic screenings necessary to detect these disabilities during growth, and it's really a snapshot. Children are seen more than 3 times in the first year, more than 2 times the second year, and then annually after the first second birthday. So, and also I want to underscore that the shortness of pediatric visits, on average, if you come in for health supervision, those regular routine appointments that are made, those are average about 18 minutes each. And if all the other visits are around 14, 15 minutes. So that's a very short period of time to do a physical assessment, listen to the heart, listen to the lungs, talk to the parent about concerns. So we really need to look at ways to assess development more easily, tools that have extensive validity, reliability and accuracy, standardized with diverse groups, and also age appropriate for the child. So that remains a challenge. So how many children are affected by developmental delays? And this, I think, can often be of major concern. We have sorry about that. Okay, about 15% of children have some developmental delays. The most common are generally speech and language, but there are intellectual disabilities and the autism spectrum disorders. This number has been decreasing in terms of an increasing ratio. So it's 1 in 54. A number of years ago, it was 1 in 100 and some. And now we're more efficient in diagnosing children that are somewhere on the autism spectrum. But the biggest thing that's of concern for us in early childhood is this aspect of how many of them are identified before they enter school. Because if they required intervention, but it was not received, they're going to kind of start school behind their peers. And sometimes it's really difficult to play catch up then. So especially if there are language delays or hearing problems or visual problems, the sooner we start some of these interventions, the better for the child. So less than a third of children are identified, of those who need it, are identified. And this figure is not that much better, even though that citation is from 1987, it's not that much better these days. So about a third of children are identified before they start school, and we can do better than that. And it's felt that many of the children who failed in school and drop out before completing high school are examples of those that required something that was not offered to them earlier. So what do primary care providers typically do? Remember, I told you that only fewer than 1 in 4 children in California is currently being screened with valid tools. Well, 71% of pediatricians identify potential problems just via their clinical judgment. Like, oh, I've seen enough children that are 1 month old, 2 months old, etc., that I can kind of make a judgment about this. Or they might even use some kind of checklist. And of the pediatricians that use some kind of screening instrument, that's 23%, but they are unlikely to use it in the recommended way. And many of them use an instrument called the Denver Developmental Screening Tool, the Denver 2, which takes a good half hour of cooperation on the part of a child to do it properly. And Neil Halfon from our own UCLA school, he identified that just a little over half of parents say that development was even assessed during a pediatric visit. So we may not be as good at identifying for parents that we're surveilling development, but we may not be doing the screening so that people know that it's happening. So why do they do so poorly? It's that reliance on clinical judgment that only is going to identify the most severe delays. if you use milestone checklists that aren't standardized, you know, how many failures are too many. And then, as I alluded to with the DDST, that administering instruments in ways that they weren't designed to be done or that they were not calibrated on will give you some bad results. So this lack of appropriate guidance does result in delays. It delays referral, and sometimes parents seek other forms of guidance from community or the online world, and they waste a lot of money and time for their children. So with the developmental screening article from the AAP, the components are universally, we will screen, all children should be screened regardless of their risk. Remember, there's a low sensitivity for clinician judgment. It doesn't even pick up 1/3 of the children who need referral. And parents might interpret a primary care provider's silence as approval or reassurance that everything's going fine. So it's universal and it's also periodic. So the periodic element of this is that at 9, 18, 24, or 30 months at those visits, and any other time that you have some concerns raised from your regular surveillance, that children will be developmentally screened. So the additional recommendations that they also have is that we do autism-specific surveillance at all visits and autism-specific screening at 18 and 24 months. And I'll share those instruments with you. So an overview of some of the instruments that are routinely used in screening. And again, why screen? This is kind of redundant, that many children that need that. But I want to underscore this social benefit that early intervention can save us as a society between $30,000 to $100,000 per child. By providing this early intervention, it prevents other problems and delays, and it gives the child a better outcome for overall development. So standards for screening instruments, the user really needs to be aware. There are hundreds of assessments being sold. The publication of these is not really a regulated industry, so people need to select tools properly based on appropriate levels of accuracy. So what to look for in those screening tools, that they're standardized on a national sample and the sample that you're working with. Proof of reliability, evidence of validity, and then accuracy. And with accuracy, we're looking at a sensitivity at least 70% to 80% and a specificity of 70 to 80% as well. So remember, sensitivity in terms of research and in tools and screening instruments would be correctly identifying those children who have developmental delay in this case. And specificity is a related concept, which is that it correctly identifies 70% or more of the children who are progressing developmentally appropriately. So they aren't really inverse. They are two kind of distinct characterizations. So the challenges, minimal reimbursement, although screenings are reimbursed. The children have a limited ability to comply with all your requests for testing, time constraints, etc. So a number of individuals, we've got to look at this from the big picture. And so most children are typically developing. They're doing fine. Parents just might need some advice about behavior. So we do that in our primary care visits. Parents, those children, though, that are having some slowdowns or have some psychosocial risk factors, parents might need some training or social services. Children might need some enrichment, tutoring, mentoring, etc. And then this smaller part of the triangle, those children who have some psychosocial risk factors and maybe some organic issues that are going on, they will need some special education, speech therapy, etc. So it's in that realm that we're looking to provide that support through the developmental screening. So poor identification of psychosocial problems if you just use some kind of checklist that hasn't been validated. And some common myths about screening are that the screening tools are way too long, they're difficult to administer, children are uncooperative, and challenges of giving anybody difficult news, which is indeed an issue. And then this referral to resources can also be problematic. So one of the big questions is, can parents be counted on to give accurate and good quality information? And through a number of studies, the answer has been a resounding yes. And these screens can be used to be as accurate as many other measurement issues, although there are some provisos. The tests do try to correct for the tendency of some parents to over-report, and then the tendency for parents to under-report as well. So this is a list that Massachusetts has. I don't think California has a similar list, but they actually outline the instruments that they approve of for developmental screening. And it's not limited to this, but these are the most prominent ones. I'm going to go over the ages and stages questionnaire, but there's Bailey infant scales of development, the child development inventories, Denver screening tests can also be used, but only if you use it the way it was intended. Early language milestone screening, parents' evaluation of developmental status, and I'll share that one with you as well, but not the one with developmental milestones. Then so that is developmental screening, and behavioral screening is also a valuable measure. And so there are these instruments that are also generally accepted with good statistical feedback on them. So the ages and stages questionnaire, that's for social emotional, that's the SE there. Various other, the BITC, the CRAFT is just a way to assess teenagers. It's a format. Modified checklist for autism, we'll go over that. We will have gone over the evaluation of developmental status, and the PEDS symptom checklist, which is a valuable and useful instrument as well, and it's free. So this looks at some of the sensitivity specificity issues with some of the instruments, and as you see, the Denver has variable, specificity and sensitivity, ages and stages, generally in the above 70 category, the PEDS. And the child development inventory also by Ireton, but that has like hundreds of questions and many pages that parents may find a little tedious, so it's a little less well used. So here's the Denver, and the Denver, I don't know if any of you have had any experience with it, but I remember back in the old days in my pediatric nursing, we all learned how to administer it. It's fallen out of favor for developmental screening in a quick way because of the parent report questionnaires that have really good sensitivity and specificity. But I really like this because it also gives me guidance as to what children can do at certain points. So in their development, and it is very helpful in that way. It's geared here for 0 months to 6 years. And when I will share with you, here's the items. So on the left-hand side, this R means 25% of children can accomplish a certain task at that particular age. This hash mark is 50%. This one on the left side of the blue border is 75, and on the right, not by that point, 90% of children can do a certain behavior. So I find this when I teach pediatric nursing students, I tell them, make a copy of this and put it in your pocket. So if you have a 11-month-old or 12-month-old, so here we have like for a 9-month-old, and you want to know, oh, what kind of things can I expect of that child? You go, oh, okay, drink from a cup. So at this point, over 25% of kids can maybe drink from a cup. cup. So, oh, maybe I'll give them that opportunity. I'll give them a cup with a little bit of water. Oh, they can wave bye-bye. Oh, look at that. Oh, good. I can go, hey, bye-bye, bye-bye. And they should respond to me. I can kind of test them for that. They can play pat a cake. Oh, good. I love playing pat a cake. That's a good one. And so is peekaboo. So then banging two cubes together. So you might even give them these cubes that they can play with. And then you know that they can definitely do some of these. They should be able to start feeding themselves, work for a toy, etc. And then some of these things that they can't quite accomplish yet, you might provide them that opportunity. So I like to use this as, kind of helping me communicate with a young child and begin to learn some of those developmental milestones that are really important. So I really do like this form for that. Have any of you used this at all or been exposed to it?
I haven't. I don't think I've.
Oh, good. Okay. Well, and if any of you did want it, I can send you some info. Good. So oh, good, Lizeth. If you're interested in it at all, let me know or let Vanessa know, and then I'll be happy. I can share with you the document. It is copyrighted, but you can even Google it and find it. So. But I think it's really helpful for understanding what children at certain ages are capable of doing. So then let's move on to the ASQ3, which is one of the measures that are sensitive and specific for developmental milestones as well. So the advantages are that this has been well validated. It's a one-time cost. It does cost money. There are opportunities to do online in big practices. Actually, they have it online and it gets scored as well. So good, great. So it's really a helpful, instrument that way. It's milestone specific and skill based. And I think it really helps facilitate education and ways that we can interact with children to foster their development. And it has options for parent administration or parent self-report. So it lends itself to a waiting room situation or exam room. Now the disadvantages are length. It has a number of pages, but there's a lot of white space. It has 25 to 35, items. I'll show you an example. They're age specific. They have logistics of kind of the correct distribution. So you have to actually calculate the exact age in months and days of a child to make sure you select the proper form. And many low literacy or high risk parents may need some assistance. And I do want to reinforce that. I've worked with the Nurse Family Partnership that I'll tell you a little bit more about in the next presentation today. But they include many, low literacy, high risk parents, and we've had to go over the questionnaires with them because some of the parents would say that their child can do everything on the list, and that is not necessarily the case because they're afraid they're going to have their child taken away if they respond negatively. So that's some stuff that we've had to overcome with some of these high risk groups. So these instruments are also free. If any of you have children and you're curious, if you have children under 6 and you're curious how they work, you can actually go to this website, plug in your child's age, today's date, take the questionnaire, and it will give you the whole assessment. So the developers are actually from Oregon, and so this is their site, not the group that sells it. So here's what the form looks like. This is the first page of the 14-month questionnaire. And if you notice here, it says, can your child do it? Yes, sometimes not yet. So does your baby say 3 words such as mama, dada, baba? And the word is a sound or sounds that your baby says consistently to mean something or something. So you score that, and you do it for all these areas. It's got the communication, gross motor, etc. So then every yes gets 10 points, every sometimes gets 5, and not yet gets a 0. And those are added up for communication, gross motor, fine motor, problem solving, personal, social. And they have age-specific cutoffs. And what I love about this is that if it's in the white zone, that means they're okay. They are, as they say here, their development appears to be on schedule, down here where it gives you the key. If it's in the gray zone, those are of concern. So there are activities to suggest, to do with the child, because maybe it's that they haven't had the exposure. Maybe it's not a language-rich environment. So encouraging that with parents and that kind of interaction is helpful. And in this black zone, that means it's below the cutoff. So therefore, we have some concerns, and it may possibly indicate immediate referral to others. Now, in this one, the higher the score, the better. A lower score means you need to act. And what I love about the ASQ3 is they give you suggestions for each of the age groups. So for example here, activities for infants 12 to 16 months. Babies love games like pat-a-cake, this little piggy. Try different ways. Arrange furniture so that your baby can work her way around a room by stepping across gaps in between furniture. This encourages balance and walking. So lots of wonderful suggestions that don't cost parents money. So the ASQ SE2, this was newly revised. This is a social emotional questionnaire, and it too is available on the Oregon website. So if you do have a child, that's great, or if you have friends that are curious. Here is a similar social emotional. It says, is it often, always, sometimes, rarely, never, and then check if it's a concern. And you notice there are Z, V, and X, and a V here. So that tells you that's a guide to the scoring. And the scoring for this then is a Z is worth 10 points, a V is worth 5, and a Z is worth 0. And if you have a concern check, that's an additional 5 points. And you'd put the points, add up each page, total it up. And this also, this is a nice new thing that it has all the score interpretation as well for the cutoff, so that you can mark it on the line. The cutoff for this age is 50. It's different for every age, so you need the age-specific questionnaire. If it's in, and here the lower score is better, and the higher score is a referral, and they have similar activity sheets. And if you're interested in any of these, I do have the I have purchased the ASQ3 and the ASQ SE2, and they're available. I'd be happy to share them with you as well. So the PEDS, some advantages of it. This is another parent-completed questionnaire. It's brief, it's 10 questions. They say it takes 2 minutes to score, but I put those red question marks in. I glaze over. The disadvantage, there are costs to it. There's no incorporation of developmental milestones, and there's some concern for underdetection. So here is the form. This is it for all age groups. First, you have the parent list any concerns they have with child's learning, development, or behavior. Then they systematically go down. Do you have any concerns about how your child talks, makes speech sounds, understands what you say, uses their hands or fingers, so that's fine motor, uses their arms and legs, gross motor, how your child behaves, that's for behavior, gets along with others, social. Their child is learning to do things by him or herself, again, social, and then learning preschool school skills and any other concerns. So here's one that, an example from their website that it's filled out. Parents put their comments in. Then you score it based on whether or not they have some concerns. Then here's a pathway that you follow. I glaze over with this, so I'm a firm believer in the ASQ 3 and the SE because of all the other supports that they have. So again, so the ages and stages one is good for social emotional, so are the PEDS. The pediatric symptom checklist is free, and then we'll go over the MCHAT-R as well. So the PEDS symptom checklist, it's free, multiple translations, it's brief. Here is a pictorial version. It comes in many languages. And then here's a reformatted version. It's also available from the Bright Futures site. But there are subscales as well that are identified on it for various other behaviors. And it's suggestive. And it's a simple questionnaire. So the MCHAT-R, this is for, remember, this is at 18 and 24 months. We universally screen all children for autism spectrum. And so this is free and it's all available. There's an online scoring one and there's downloads. So if any of you are interested in this, you have friends or relatives that want to know, oh, does my child have autism? The proviso is that this has only been validated for 16 to 30 months, so that's why it's only recommended at 18. Scoring isn't straightforward. You have to reverse score a few items. It's got a high false positive rate, and it was designed that way so that it would maximize sensitivity to pick up children. And there are follow-up interview questions available that you can follow through. And it was revised 2009. If there are more than 20 items, that means it's an older version. So there are the 3 items that the yeses score or risk points, whereas in general, it's the no's that are risk. So if you point to something across a room, does your child look at it? If they say no, that's a risk factor. So 0 to 2 is low risk. You want to repeat it at 24 months. And then 3 to 7 would be medium. And so you might do these follow-up questions. And a score of 8 to 20 means high risk, and you really should refer that child immediately. And for surveillance, this is a nice poster from UC Davis that looks at some of the things that are important in surveillance, but certainly the lack of eye contact is the hallmark that practitioners look for. Then also by 6 months, no big smiles. 9 months, no back and forth with sounds, etc. 12 months, don't respond to their name. And by 16 months, they don't have any words and language, so that's often a concern. Then for depression scale, one of the elements is the PHQ-9. I'm assuming you may be familiar with that. It's available, lots of different formats, also from, I believe, Pfizer, the company. And then for maternal depression, it's a specific for postpartum depression, is the Edinburgh postnatal depression scale. And that also is important, and especially looking at, is there thoughts of harming yourself or your baby? So in conclusion, we do surveillance at all the well child visits. We do general developmental screening on all children at 9, 18, and 30 or 24 months, using instruments that have adequate sensitivity and specificity, and therefore considering parent completed tools, and then autism screening at 18 and 24. And there are some good websites about learning the signs. This focuses primarily on developmental delay in many areas, and I found it real helpful. They have milestone tracking and good advice for both parents and professionals. They have some good written checklists for parents too. So really, we're looking at these children. Most children are going to be developing fine normally. Maybe they have an illness, they slow down a little bit, but then they catch back up. But then there are those children who just are slower intellectually and then some that hit a plateau and just stay there. And then the neurodegenerative where they actually regress, those are of concern. So here are some of the red flags. I'll leave these for you to look at, of the various different ages of concerns that we might have for saving time. Each of these may indicate some problems. In language, one of the things that parents often question is, oh, you know, oh, people can't understand my child. Well, we don't expect most strangers to be able to understand a child. But, and so we have this rule of fours. That's a nice surveillance guideline that, so you divide their age in years by 4, and that tells you how much of the language should be understandable by a stranger. So about 25% by 1, 50% by 2 years of age, 75, and then by 4, 100% should be understandable. And if that isn't the case, then certainly language referral. And this has some other, the preceding slide, that some immediate speech therapy ideas of if children don't use at least 3 words by 15 months, doesn't say mama, dada, other names by 18. So these are definite good indicators for referral as well. So we're bringing in referrals. Many times people don't understand what happens. And with the screening results, then you want to get real evaluation and want to get a diagnosis so that you can look at early intervention, what kind of services are needed, and maybe even enrich developmental experiences. So understanding where we have resources, we're fortunate in California, there's an early start program where there's an 800 number, anyone can call it, associated with the California Department of Developmental Services, that's DDS, and so it doesn't mean dentistry in this case. So 0 to 36 months, they coordinate all services. After 3 years of age, after that 36 months, then school districts are the ones responsible for early intervention with children. Be self-referral, professional. The more information you have, the better. They have this website that has information on birth to 36, the regional centers, and consumer corner, so lots of good information and publications. Here's a whole resource that explains all the programs, has parent interest brochure. So here is the kind of flow chart: referral by a professional, a parent, or concerned person. Now, the more information you have for a referral, not just, I'm concerned about language delay. What you want to do is on the ASQ, the child falls below the cutoff for blah, 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 and blah, blah, blah. That will give the referring agency a lot more information. So once the call comes in, they have about 45 days to deal with the referral, and then and they refer to the regional centers and all that. So the more precise your referral, the better. And if you have your professional credentials and all of that, that also can help. So we're fortunate in LA. We have 9 regional centers. 1, 2, 3. No, I think I think there's nine regional centers in LA and more in all this area. Depends on your zip code, and they are very rich resource to serve children and families. They have Family Resource Center too. So I just wanted to make sure that all of you are aware of that as well. So I'm switching my screens now. I am going to share my new screen to go into home visiting. So are there any questions on the developmental screening? Was there some new information, I hope?
Yeah, there was.
Yeah,
Thank
lots
you.
of new skills, yeah.
Oh, good. And I find it, you know, I like showing you the instruments myself, because then you go, oh, okay, so that's what that is about. And you know, with my peds nurse practitioner students, I make them do a ASQ3 and an SE2 on a child, usually a friend's child if they can, so that they can see how to use it. And what they almost always respond is that most of the parents have never filled one out during a well child visit. And in addition to that, they have they really enjoyed filling out the form, and they learned a lot about their child. And one of the important questions in the end there, and I didn't show those to you, but when you see the individual forms, you can see them, is, you know, what gives you pleasure about your child, or what do you find positive? And it's really fun to read the parent statements, because they go, she's got a delightful personality. I love how she hugs. I love it. So when a parent has positive feelings about their child, you know, that's really something that we can all build on. And I find it really, you know, encouraging. So, and in fact, the parents really enjoy doing it. A couple of them have had their spouses complete it, because they're usually the ones taking the child to the early, you know, preventive visits, and they end up, you know, the spouses go, oh my gosh, I'm gonna have to fill that out, but they've actually enjoyed it, and so it's kind of been a nice experience for the nurses that I work with too. All right, so home visiting in early childhood, this is a upstream approach and with a public health focus for families, and particularly young families at risk. So I wanted to give you a little bit of background about that. Hamida felt this was an interesting topic when we first started doing my lectures. So, you know, I'm happy to share this. So I want you to be able to know some advantages and disadvantages of home visits, and then identify two evidence-based models approved by the Department of Health and Human Services to provide home visits for high-risk moms, infants, and young children using Affordable Care Act funds. So you're actually going to learn some of that. So my outline is really, what is home visiting? You know, nursing has a very long history in public health nursing, particularly, of doing home visits. Why the focus on infancy and why home visiting? And some of that has to do with ACEs, and then also the Affordable Care Act has worked to expand opportunities for home visiting across the country. So I'll let you know about that. So if you have some families that you may want to refer, you actually can do that. Then evidence-based home visiting and the focus of that from the Department of Health and Human Services perspective. They have categorized various models as eligible for funding, and that includes one that I was associated with developing, the EIP, the Early Intervention Program for Adolescent Mothers, and the Nurse Family Partnership, which is also a public health nurse mediated home visiting model. And then there are other ones. Many of you have heard of Early Head Start. They have both center-based and home visiting and mixed models for that. And another very popular one is Parents as Teachers, and I'll give you the list of all 21 that have been approved. So public health nursing, this is Henry Street settlement in New York, where Lillian Wald was associated. And so often it was dealing with the children of many of the immigrants and families. Here's a public health nurse in New York City. Rather than walking down to the street and then up the stairs in the next building, she goes across the rooftops, and that bag there, that's the classic public health nursing bag. It's kind of the Mary Poppins bag, where just about anything you need for a home visit is inside that bag. And here's actually a public health nurse doing a visit at a home with the children are there. And you notice she's laid out newspapers. That's exactly what we did. You'd lay out newspapers to protect your bag. You'd have a surface. You put your bag on top and then open it up, and all the different things that you needed were in there. After World War I, there was an increase in public health nursing with various laws that funded nurses in the community. We had visiting nurses, maternity centers, clinics for infants, mothers, and then insurance companies saw the value in this and started providing visiting nurses as well. The advantages of home visits have been very clear to us in nursing, that clients have much greater control over their health and their lives. You have access to families to provide health education and other prevention strategies to everybody. And there's an opportunity to observe family and environmental factors that can influence their health. Home visits allow for this primary intervention and disease prevention so that we can prevent injury as well, and that they facilitate family participation. Many times it's only one parent and there's no siblings in on visits. And so, doing these home visits can be very helpful. So the disadvantages, however, they're extremely time consuming. As you might imagine, the travel time required can be quite costly. And the personal safety in some community and family settings and public health, we learn if you have a sense that this is not a safe situation, get back in your car and head out. That is a very important part. I have also found, however, that many of our families will look out for our safety. We would make phone calls, and I had students visiting patients in Nickerson Gardens in South LA. And this was during a period when it was heavily gang-ridden and lots of violence was occurring, and they would actually tell the visiting nurse, please don't come today. There was something that went down late last night, and it won't be safe. And in many of these communities, it was not at all unusual for nurses to wear their white uniforms, because then they would be identified by members of the community as a healthcare professional. And in fact, long after we gave up white uniforms in many hospitals, in some of our higher risk parts of the community, nurses still wore white uniforms and even their nursing cap, not as a deferential to tradition, but mainly to identify themselves as healthcare providers in the community, and that was actually quite respected at the time as well. So and there's less control over the care setting, like there might be cleanliness issues. I know in some of the areas, and this is even recent, people said you couldn't even really put your purse down because there were lots of roaches crawling around on the floor, etc. So you really gain an appreciation for the kind of environments that families are struggling in as well, and distractions. So ACEs, I'm assuming maybe you've already had some content about ACEs, the adverse childhood experiences.
A little bit, yeah.
Yeah, okay, good. So I just want to reinforce this because this is one of the big instigators, along with toxic stress, that influenced a number of researchers in the early in 2009 and 10 to then lobby Congress to provide funds to provide interventions for families that had likelihood of exposure to these adverse childhood experiences. And the whole premise, Vincent Ferlitti and Robert Anda in '98, and I believe they were physicians in San Diego with Kaiser, they learned, they were seeing some of the same repeated patterns in a number of people they were treating for obesity. And part of this revolved around very tragic and complicated historical events in their lives that seem to repeat. So, and so they developed their form, and actually the copy of the form I think is on the next slide. But the premise of this is that because of these adverse childhood experiences that the child actually has no control over, this sets up some social, emotional, and cognitive impairment that then leads us to adopt health risk behaviors. And this adoption of health risk behaviors then causes disease, disability, and social problems, and those then all lead to an early death. as well. And so there are lots of associations that with different kinds of experiences. But so they look at a physical, emotional, and sexual abuse. They look at neglect, physical and emotional. They look at household dysfunction of mental illness, having an incarcerated relative, substance abuse in the family, mother treated violently, and divorce. Now, the possible risks of outcomes include lack of physical activity, smoking, alcoholism, drug use, missed work, and associations with physical and mental health of severe obesity, diabetes, depression, suicide, STDs, heart disease, cancer, stroke, COPD, and broken bones. All of those have been associated with these ACEs. So this is the actual questionnaire and the 10 questions, and you add it up and you get a score. So you can look at the PDF of this lecture and you can see all these. But the lifespan impact of ACEs, and I like this, that these adverse experiences and critical sensitive developmental periods and then adding genetics in can actually rewire our brains. And that can then affect how we adapt to the world. And I like this that I found online, because I think it kind of shows this is what we're trying to impact when we deal with trying to eliminate these adverse experiences, prevent it from going on with the next generation. And this actually then shows some differences of brain, a healthy brain and an abused brain. The temporal lobes are nearly quiescent, meaning there's not much activity. And whereas here, there's a lot that goes on. So I think this is like the reinforcement that there is some validation in the rewiring hypothesis. So toxic stress is another element as a result of all those ACEs that has helped us like reformulate how we look at these events that happen in children's lives. And so positive stress, we all need a little bit of stress to learn to cope. But if it's brief, increases in your heart rate, mild elevations in stress hormone levels, that can be usually positive. You get over it, you learn, you go, wow, I did that, no big deal. Now, tolerable stress might be a little more serious, but it will be buffered by having supportive relationships. However, if you have toxic stress, which is of concern, it's kind of the relative severity and a prolonged activation of the stress response in the system, and in the absence of protective relationships. So if you have limited resources and are in poverty, you really are at high risk for this toxic stress, which can then work at how you adapt to your world as well. And one of the points I would like to reinforce is that if you have at least one positive caregiver, even if your parent has mental health issues, that usually can bode well for the child as well. So here are a number of researchers that have done work on looking at the brain. This Harvard Center for the Developing Child is a gold mine of information about toxic stress, and as well as children's neurodevelopment. And Schoenkoff and others were responsible for getting these early home visiting interventions. So these are some slides from this Harvard Developing Child framework that I just want to kind of quickly remind us of, because they relate to some of the developmental things that we talked about just moments ago. So 700, 18 months, 90 to 100%, 3 to 1, and $4 to $9. So here are numbers to remember. So we have the 700 new neuronal connections per second. In the newborn, you notice they're not connected, and here they start by 6 months. They're really proliferating, and they're really going gangbusters by 2. Now, myelination of the nervous system, and this is showing that increasing myelinization. that happens by stimulation. You know, you interact with the environment, and that stimulates this proliferation of connections. If you don't have interaction with the environment, this proliferation does not happen. So it's very important that a child have positive interactions, you know, with the environment. 18 months. This is when the language disparities begin to emerge, and if no intervention happens and this is sustained, then these children here are going to start school at a serious disadvantage. And so the children of college-educated parents are going to carry on, whereas if there is not intervention, we don't increase the language, then those children things may be set for them. So this is much of why early Head Start went into play as well. Remember, Head Start started at 3 or 5 to 5 years before kids went to kindergarten, and then they discovered that that was too late. So this is why language disparities are really important for us to intervene with. So here we have 90 to 100% chance of developmental delay with increasing risk factors. Now, this is not ACEs. This is just series of risk factors that would include, you know, poverty, single parenthood, a number of different things. So when you look at this, we've got with 4 risk factors, you've got almost 50% chance of delay. 5, you move up close 75% and almost 100% by the time you have 7 risk factors. So this again is motivation for early intervention for those children. And this one relates to the ACEs more, the adverse childhood experience. So 3 to 1 odds of adult heart disease with 7 to 8 of those adverse life experiences. You know, that just helps reinforce. And then the savings and return for every dollar spent on early childhood programs, we can save society a considerable amount of money. And right here, I'm going to talk more in a little bit later about the Nurse-Family Partnership, which for every dollar spent, they save $5.70. And this was a RAND Corporation study that really helps reinforce why we need to invest in these prevention programs. So that brings me to the Department of Health and Human Services and the Administration for Children and Families that have this HOME-V evidence-based models website from which some of this information comes. So home visiting evidence of effectiveness, that's what HOME-V means. The government loves all these acronyms. And so when Schoenkoff and David Olds and a number of other prominent developmental researchers collaborated together to try to get Congress to agree to fund some of these high-risk programs, they really wanted to have it be evidence-based. So they were able to convince them that you know, if you give us this money, it should only go to those projects that have evidence base to them. And, you know, so that gave birth to, they call it MCV, Maternal, Infant, and Early Childhood Home Visiting. And that's part of this HOME-V. So it supports pregnant women and families and helps at-risk parents of children from birth to kindergarten entry tap the resources and hone the skills they need to raise children who are physically, socially, emotionally healthy and ready to learn. So some of their outcomes or benchmarks that were included in the original studies that were the basis for the first rounds of funding But over time, families, health visitors build a partnership, work together to improve health and development, prevent childhood injuries, abuse, neglect, etc., reduce emergency department visits, improve school readiness and achievement, reduce crime, including domestic violence, improve family economic self-sufficiency, and improve the coordination of referrals for community resources and support. So all of these things are what's included in the cost savings to society for every dollar of investment in the program. So a Congress in 2010 established the program with an initial $1.5 billion investment, but only for evidence-based models. And I think this was a very smart move because, you know, there are many studies that are done that people think might sound like they're effective, and maybe there's someone's pet project, so it got funding, but they don't have any evidence of benefit. And the concern that David Olds and others had was that money was just being thrown away and actually not good for the early intervention community, because then people say, well, we spent all this money and it didn't do anything. And that was because these weren't evidence-based models. So they really pushed that thrust. So as late as March 8, 2018, that budget extended the funding to fiscal year 2022. So the funding has been secure, $400 million a year to support these high risk and very good bipartisan support. I'll talk to you a little bit about that too. So HRSA, in close partnership with ACF, funds the states, territories, tribal entities to implement voluntary, and that's a key word, evidence-based home visiting programs using models that have been proven to improve child health and be cost effective. So the federal home visiting program has provided over 1.4 million home visits since 2012, et cetera. And about 50% of these are also rural. So there's nice representation across the country. So here are some of the, here's a map that shows some of the counties in the United States where funds for these visiting, home visiting programs have gotten. So what are the programs that meet these criteria? And this is the latest December 2019 list of evidence-based models. And as you see here, it's an alphabetical list. This is Early Head Start, which their home visiting component that serves 0 to 3. The Early Intervention Program for Adolescent Mothers, that's Dr. Deborah Cognac-Griffin and myself from UCLA. Early Start in New Zealand. Family Checkup, this is a wonderful program out of Oregon about behavioral management, and it's a home visiting. Family Connects, this is a universal home visiting, kind of the old public health nursing model where everybody that delivers a baby gets a visit by a nurse, and then they connect them to services in the community. And then Healthy Families America, I've got Hippie, home instruction for parents of preschool youngsters. Nurse Family Partnership, that's a public health nursing program that LA County and LAUSD both provide, and Parents as Teachers as well. So here is a map of California. California, each of the states had to, they had needs assessments for every county, and then they chose which models that they wanted to use. And on that list of 21, there were 11 original models that were in 2010 identified at the time. And so people could only choose from those 11 models. Well, our model, the Early Intervention Program, was the 12th one that came in 2011 after the money had been distributed. So, you know, in general, it's the groups that were early in on the funding that have been able to be sustained, because there is no money for development built into the legislation. So that's just an issue. But in California, we've got mixed, both nurse-family partnership, healthy families. Now we have early Head Start home visiting programs, but they are not necessarily funded by these monies. So just so that you're aware. And here is just to kind of explain where we are. So the NFP started in the 90s. They had a lot of research. Our EIP, we did our research, published it, our funding, we had an R01 from the federal government. It's the kind of top of the line 5-year research grant. And then we had publications to 2003. Then it wasn't until 2011 that they discovered our literature in the nursing literature, and we ended our work here. It was a research project. We weren't able to get any extra funding, so that's effectively when the program stopped. So there were 11 models here, then we were the 12th one, but the money had already been distributed. So in 2015, they had analyzed 44 models, and there were only 17 have met the criteria of evidence-based. So, you know, I feel really very excited that we met that criteria. But so David Old's program, the Nurse Family Partnership, this has years and years, 40 plus years now of research behind them. David Olds is a child development psychologist, and Harriet Kitzman was the RN that collaborated with him in the original work in Rochester, New York. And it's been replicated all over. It has an international base, but through these very planned and well-documented PHN home visits with trained public health nurses, they were able to improve this whole host of outcomes. They had fewer repeat pregnancies, improved prenatal health, fewer language delays, fewer child injuries, increased maternal income, fewer arrests, all of those that are positive. So that it's effective. For every dollar, it saves $5.70. So there is an intense fidelity to the model. They have a national organization, wonderful success stories. I'm really proud to be a part of having students gain the experience to be with the LA County Family Nurse Partnership. But they have intense public health nursing visits in the home, begin prenatally, and then at birth every week, then every other week, and then every month until the child's 2 years of age, and then they slow down. But it's all over LA and the county. And if you do encounter someone, their focus is first pregnancy. Try to enroll them before the 28th week of gestation, primarily under 26 years of age. Priority is often to teen moms, and it's been newly expanded in LA County to multipras, women who have had more than one child. But if you are interested, there is a link to the LA County Public Health website to go ahead and get people signed up. So what's going on in California? Again, Children Now in 2018 gave us a D+ for home visiting in terms of we're just not reaching enough people. So home visiting programs reach fewer than 3% of California families. 62% of babies are born to low-income households, so that's automatically a risk factor. 41% of parents report having one or more concerns about their child's development. And we saw how screening isn't happening. 1 in 6 women report prolonged depression while pregnant and after their baby's born, and over 40,000 infants are born preterm, making them susceptible. And in reality, many of these programs cut down on that preterm birth aspect by providing moms extra support. So the programs do provide support for both the mom and the baby, promote positive parenting, help families set goals, and help parents understand on their child's development. So I want to give you a little bit of an insight into the early intervention program that Deborah and I spearheaded back in the 90s and that got this designation. It was a randomized controlled trial, so it was a research study. We did it in San Bernardino County. At that point, we had an affiliation. We had a former graduate of the UCLA School of Nursing who headed up the community nursing division of the public health department for San Bernardino. And she was extremely interested in having us do this. So we randomly assigned, everybody had an equal chance of getting into the EIP or traditional public health nurse arm. So the EIP received preparation for motherhood classes and a couple of prenatal visits, had monthly home visits by the PHN just to 12 months of age. Remember, we talked about how the NFP goes to 24 months, and we used video feedback to encourage teachings in parents. And then traditional PHN was 1 prenatal visit and 1 to 2 postpartum visits where they referred them to community resources. So we called this routine. So they all got something. It wasn't that they didn't get anything. And then our research article, if you're interested, I can actually forward it to Vanessa. She can post it too, so you can have that if you wish. So long-term, our 24-month outcomes, statistically significant, favoring the EIP. We had less ER use, and we did full medical records review. And if any of you have been involved in trying to do that, it's a pain to try to get medical records from agencies, multiple agencies. So we had to be very persistent, but we got medical records. So it wasn't just maternal self-report. And this is what I think helped with the designation of an evidence-based model. But so there was less ER use, fewer hospital days, fewer number of hospitalization episodes, and shorter mean hospitalization per every hospitalized child. And self-report, there was less substance use than the traditional group. There were no differences in parent-child interactions, which we had hoped to impact, and or on the home inventory. And then just wanted to note that. So the way we were designed, our aims were to improve maternal infant health, decrease, eliminate high-risk behaviors, promote effective family planning. That's particularly difficult on the spacing of children. We found teen moms had they had a life plan for themselves that often included, having another child within a couple of years. So it's pretty hard to intervene in that. Enhance their life skills, complete school, think about employment options, know your resources, and learn how to effectively make decisions. Many times they had knee-jerk reactions to the very stressful kinds of situations they had. And all of this was done by improving the mom's competence with the therapeutic nurse-client relationship and building on their skills in the home environment. So core elements, we had nurse case management, prenatal education, prenatal visits prenatally, and postpartum. We had a protocol manuals that we developed and referrals for supplementary services in the community. And then unique features, had adolescent theory and maternal role development as a basis. We had the 5 domains that we looked at, and I'll show that. And parenting skills. We used nursing child assessment, satellite training, parent-child interaction scales to help moms become better in their interactions and developing the development of their child, and then demonstrating newborn behaviors and the variability and individual differences, as well as then using video instruction feedback to have the parent teach their child to do a task and then see how the parent responded. We also encourage this decision-making, problem-solving with the moms and a kind of bi-directional written planning. So here are the five areas: health behaviors, maternal role and parenting, sexuality and family planning, support systems, life skills that we focused on. Parent-child interaction, we use Kathy Barnard's nursing child assessment, satellite training, parent-child interaction scales that were previously validated. She also has, the part of her model that we like is that parents bring things to the interaction, their sensitivity to a child's cues, how they respond to distress, how they foster cognitive growth, like labeling colors and articles like that. Oh, look at the dog over there. Look at that green button. Look at that. And then social emotional growth fostering as well. But children also have characteristics that are important in an interaction. How clear are they with their cues, and how responsive are they to a caregiver? We all, hopefully many of you have had the experience where you held a baby and babies just melt right into your shoulder, under your chin, and they're like really good cuddlers, and that makes a caregiver feel so warm. But there are some other babies that you'll put up and they will just stiffen up, and they don't like that, and it feels, some parents will interpret that they don't like them. But so it's very important, and that in Kathy Barnard's model, the child influences the parent just as the parent influences the child. And that we need to have reciprocal and contingent interactions, which is kind of like turn taking, serve and return. And that this is an important part of developing those nerve synapses. She also has a teaching loop model that is probably very universal, where you first alert, you give instruction, and then you give them time to perform, you give them feedback, and then you might repeat that again. And that this is part of the model. And so this is similar to the serve and return of the developing child. So the infant cues, and there's a long, long list of them, but there are engagement cues and disengagement cues. So in the engagement means I'm ready to interact. They might smile, they might reach toward you, they brighten, they still, etc. Disengagement cues, we have potent ones: back arching, choking, halt hand. That's putting your hand, and many of you, if you've tried to feed a young child and you bring the spoon to their mouth and they put their hand between their mouth and your spoon, that's what we mean by halt hand, that they stop it. Or they may even turn around in their high chair so that you don't get the spoon near their mouth. Those are disengagement cues. They mean that the child needs a break. Doesn't mean that they need to stop. Maybe it just means yield. But sensitive caregivers learn to determine the difference. So the teaching scale is what we use, and I like it because it's a novel situation. It creates some stress in the interaction. It only takes 1 to 6 minutes. And so this is, that blue sheet shows the first page of 2 pages of the scales that actually are used to look at. There are 73 items in those 5 subscales that I previously reviewed that you score yes or no based on your observation. So we videotaped these, and we didn't find much difference in our moms. But one of the things that we see is, like, here is a typical teen mom baby interaction, especially with a depressed mom, that there's less verbal, there's less responsiveness to infant distress. And one of the Boston researchers, Tronick, did a lot of still face experiments in the 70s and 80s. And in those, they're very powerful to look at, because they had moms interacting split screen with their child, doing a normal interaction. Then the moms were instructed to just be still face, don't respond to any of your child's efforts, which the moms found to be very, very hard. But you would find babies just really working hard to get their parent to interact, and then eventually they would give up. In fact, some of the babies even threw up because it was so stressful to them to not get a response from their parent. So this is one of those things of why assessing for depression in young moms is extremely important, so that we don't set it up. And as you notice here, this is from Teen Mom, the TV show. This mom actually had the baby taken away from her, but here's the baby. Notice there's no eye contact. The baby's looking away. The mom's disinterested. Yes, she's holding the baby, but that's about the extent. Then the Brazelton Neonatal Behavioral Assessment Scale. This is T. Barry Brazelton, who died a couple of years ago like 90 plus years. He has a neurologic exam that he did, looked at individual differences in neonates, 28 behavioral items, a whole host of reflexes. You can find more information. Research instrument, but we used it and applied it more as a neonatal behavioral observation. I'll share that. We looked at infant states, deep sleep, light sleep, drowsy, quiet alert is the best time you can interact. We did things like habituation. How does the baby close down to being presented with 10 stimuli of this bell? We did a flashlight to visual, rattle, and a bell. Here's orientation. How can they follow that red ball? And there are some babies that have a beautiful, smooth 180-degree arc, and others struggle to maintain a focus on that. We look at how do they orient to the face, the voice and the face, the rattle, and a ball. So it's a pretty lengthy exam. So we modified it by observing just what was the general state, tone, how did the baby habituate to light, rattle, and bell? What were some of their reflexes? How did they orient some of the social interaction to face, voice, rattle, and the bell? And they then did some advanced neuro testing of pull to sit, placing reflex, walking, crawl, tonic neck reflex, and spin, nystagmus, and the Moro response, which is kind of like the startle. The other thing that I like and that I use to teach moms how to intervene with a crying baby is their sequence of events, when a baby's crying. So first you observe, does the baby do anything to self-calm? Like, do they get their thumb to their mouth? And some babies can actually get their thumb to their mouth. Others, it's like there's a shelf at their chin. Do they smile? Do they have color? Do they have lability of states? What happens? So then you present the human face and wait. Then you do the face and the voice. A hand on, if that doesn't work, face, voice, hand on belly, they're still flailing around and crying. You then would try holding down one arm, hold down both arms. Then you pick them up and hold them. Then you pick them up, you rock them. Then you do swaddling, step 9. And the very last thing is offering a pacifier or sucking on a clean finger. So in our previous study, we had seen moms improve their interaction scores, but in this study, we were not able to appreciate that same thing. And so when we look at when has a baby had enough stimulation, here are some signs that they might have some color changes, rapid breathing, the startles and tremors, jerky movements. They start shutting things out, moving from a drowsy to a sleep state, etc. So there's some good things. And about infant crying, there is a natural trajectory to about 3 months, then it decreases. And there can be complications with high frequency cries. Those are found to be pretty irritable by adults. Teen moms and crying infants, we found many of the moms think they're going to spoil their baby if they respond to the cries. So we had to overcome some of that, and they kind of waited for their baby to calm themselves. And then I'll just kind of quickly, 2 seconds, the Pew Institute did some focusing on the whole concept of home visiting. I think some important things that came out that when you were talking to Republicans, you needed to encourage that the parents had to volunteer for this. They really didn't like anything that was required by the state. But for Democrats, it was the positive effect on parenting that was important. One of the other things is that moms respond better to mom-focused messages than they do to kid-focused. So that was an important thing. And the benefits, so the greatest benefits were personal, emotional support for the mom, referrals, etc. But ranked low is this providing a stimulating environment for your child, etc. And so when you meet the needs of the mom, you empower her to meet the needs of her child. And flexibility is needed. Many of these people have big issues. home visiting as a term is not appreciated as much as things like offering family support. It sounds more like protective services, coaching, et cetera, is better. And who do they, who have the more favorable titles? So family support providers, family support coaches, nurses were really high. And I just like this to reinforce, this is National Nurses Week. I think Tuesday is the 200th birthday of Florence Nightingale, but the Gallup polls have found nurses to be the most trusted profession. Past 18 plus years, I think they only added nursing in 1999. And so as you see, 85%, we've got doctors, our next medical providers, down at 65%. That's a wide gap, a 20% difference of, you know, most trusted. So, you know, we have a good record for that. And so they're very welcomed often in homes. So here's more information if you want more about the home visiting concepts, but I thought hopefully that ends it for me. I'm sorry I took you like 5 minutes over, but any questions that any of you might have?